I would like to introduce our next speaker. So appreciative for how far he's come, as well as Pat. Dr. Daniel Cameron. My first interaction with Dr. Cameron was via phone. I woke him in the middle of the night. We were stuck in Atlanta due to weather on our way to consult with him. And knowing that I was going to miss my appointment the next morning, we needed to make a decision on whether to try to get to New York in snow and rain and weather, or just concede and fly back to Colorado and give up. And when I called Dr. Cameron and woke him up, he very kindly and without hesitation responded that if I could get to New York, he would see me, and I knew then I would be in good hands. Now, the next morning, however, when he poked his head in to see what patient had the nerve to wake a doctor they've never met before, he smiled and told me that paybacks are, well, you know. So he got his paybacks this morning when I called him to see if he needed a ride to the venue. And he said, well, what time is it? I said, well, it's 8:15. He's like, oh, should I be getting up? And I was like, yeah, I think maybe you should probably get up now. He was finishing his breakfast with Pat, and he paid me back. So with that, Dr. Cameron, he graduated with degrees in medicine and epidemiology from the University of Minnesota, followed by residencies at both Beth Israel Medical Center and Mount Sinai School of Medicine in New York City. Dr. Cameron has led ILADS, ILADS, the International Lyme and Associated Diseases Society, to new heights as president. He has pioneered the field of clinical epidemiology and Lyme disease as author of both the 2004 and the 2014 ILADS evidence-based treatment guidelines, analytic reviews, and clinical trials. Dr. Cameron has been treating patients with Lyme disease in his private practice in Mount Kisco, New York. He regularly communicates by blog and Facebook at www.danielcameronmd.com, and is with our greatest pleasure, Nancy and I, this entire forum, welcomes Dr. Daniel Cameron to speak. Thank you.
Thank you, everyone. When I got the call to come out here, it was a pretty easy call, and I just had to do payback. Pat and I were in Maine, so knowing that Pat speaks before me, it's daunting at how good a job she does, so that in Maine and this time I just changed up everything so I could just build on the foundation she offers when she starts a session like this. So, but because I've been an internist, I've been in practice, and I've been an epidemiologist for 29 years, is that I have done an awful lot over the years. So I thought I'd start by dwelling on where I've been, what kinds of things I've done in the last 29 years, both to show you how to read the literature, understand the literature, and how to understand what doctors have to face, and that will help a great deal toward getting you guys excited about offering something in the future. So there's 4 areas I was going to talk about because I spend so much time on evidence-based research. The first one is evidence-based research itself. So years ago, I thought I should, as an epidemiologist, do a double-blind, randomized, placebo-controlled study. I enrolled 84 patients, got IRB approval, did everything right, did 3 months of amoxicillin and placebo, measured their quality of life, and the amoxicillin group did better than the placebo. Now, I wasn't offering anything for co-infection. It was kind of early in the career. I wasn't offering follow-up past the 3 months. Also, the 46% treated with amoxicillin that did well, it's lower than in real life, because if they dropped out because of being quite sick, the 46% would have been higher if I had taken those who finished the trial. So all this study said is that it's not easy to put people in trials. It's not easy to measure outcome. It's not easy to treat patients. And so I published that paper. The second paper I did early in my career was I did something called the case control study. That means I had a huge registry of Lyme patients in my practice. I probably had 2,000 patients in my registry, but that was a lot of data. It was like a mountain of data. I think Dr. Marks is here today, knows what happens when you got a lot of data and how do you turn it into something. So I decided to take all those who had Western blot tests, that had 5 out of 10 Western blot tests, take that subset of 100 people, the first 100 I saw, and say, well, what's special about someone who has 5 bands on a Western blot? Because at least these people everybody agrees they've had Lyme. And what's special about somebody who fails treatment versus somebody who has successfully treated? So I published a paper called Treatment Delays as an Independent Risk Factor for Treatment Failures in 2007. But it allowed me in this one journal to at least give examples of the kind of patients who have 5 IgG Western blot bands. What was their illness in the first place? And was there any opportunities to try to get them diagnosed early? So the reason I'm bringing this chart up is that, I'm in Colorado, and you might think that Lyme patients are rather strange. Their first presentation is rather strange, but they're actually not that complicated. When they get overlooked, you look back on it and say, well, why didn't I notice Lyme at the time? So the first case was sick for 8 years after an erythema migrans rash. They tested 1 week after the rash, but because the test was negative, the doctor didn't treat, the doctor didn't do the follow-up, and the doctor missed the opportunity for 8 years. The second one was a 16-year-old girl who had been told she had Epstein-Barr, strep infections, the tonsils were removed, but they overlooked Lyme for 8 years. Third was a tick bite followed by a swollen knee. Now, in Lyme, when they discovered Lyme, that was a swollen knee with fluid building up in the knee. And but some people just call it a tear, call it a strain, but they missed the opportunity for 6 years on a 57-year-old. And then the fourth one was Bell's palsy, did poor in school. The next was 6 by 6 inch rash. The next was typical symptoms, but they were told it wasn't Lyme by 2 doctors. And you think if you hear it from a doctor and they tell you for sure it's not Lyme, how can it be Lyme? But it turns out doctors are quite divided on the East Coast. You might think they're divided out here, but there's big divides. It's very easy to find 2 doctors in a row who will tell you don't have Lyme, no matter what your presentation is. The Bell's palsy, told it wasn't Lyme based on a negative spinal tap. The original description of spinal tap, only 1 out of 10 had an abnormal spinal tap. So therefore, if you get an abnormal spinal tap, you shouldn't be throwing Lyme away. You should look again at that patient. And then sinusitis, 2 sinus surgery. Lyme often creates pressure here and here. But if it happens to be over here, it mimics a sinus infection. So therefore, instead of exotic, complicated illnesses, this group of 100 patients, those who had delayed treatments, their average delays were for years, were all relatively simple, straightforward things that you see in an internal medicine practice. Fatigue, concentration, sleep problems, aches, water on the knee, arthritis, sinusitis, migraines, rotator cuff rash, Bell's palsy, cellulitis. Now the cellulitis is tricky because there have been several key studies showing that cellulitis and Lyme look alike, and people were getting treated for cellulitis several times with Keflex before they realized that it was Lyme disease. Fibromyalgia, chronic fatigue, and Epstein-Barr. So I published several other papers over the last few years that are considered analytic reviews. Instead of me generating the paper, instead of me doing all the work, why don't I review as an epidemiologist what's right and what's wrong. So I came to the conclusion that the clinical trials validate the severity of persistent Lyme symptoms. These are the trials sponsored by the NIH. There's insufficient evidence to deny antibiotic treatment to chronic Lyme. That's in medical hypothesis. A paper called Proof that Chronic Lyme Disease Exists, reviewing all of the evidence that leads to evidence for chronic manifestations. Generalizable ability of 2 trials. There's a lot of trials that were where people are sick for 4.7 to 9 years, and so you try to not assume too much from someone too long. They're much more complicated, and they're not the kind of person that's going to get better with a simple treatment. And then there's overlap between Lyme and PANDAS. PANDAS is a syndrome where you can get sick in response to strep, and it's very similar to Lyme disease. So the second part of what I'm talking about today is evidence-based guidelines. So in order to do more than just writing, is there a way in my practice to see if I can introduce some change? Can I get doctors to look at Lyme a little bit differently? And so that's only possible if you have an organization to work with. So Pat Smith, even though she's an ILADS member, she forgot to mention that she's one of the founders of ILADS, very instrumental in its early days of making sure that it happened. So by having a Lyme Disease Society, the International Lyme and Associated Diseases Society, it could evolve so it could have a treatment guideline. So in 2004, I worked with a group, and 2014, I worked with a group so that we can have a group-generated set of guidelines. We can look at evidence from our perspective instead of only looking at it from the IDSA perspective. So when we look at the IDSA, the Infectious Disease Society of America, they put out guidelines in 2000 and 2006. And there's pretty much 3 recommendations that stand out in those guidelines. One is that if you get a tick bite, and if you want to prevent Lyme, you should give each patient 200 milligrams of doxycycline. That's it, 2 pills. If you have an erythema migrans rash or any presentation of Lyme, 10 to 21 days is the recommended duration, and you shouldn't retreat except for a few cases of Lyme arthritis, and was mentioned earlier, maybe some cases of some neurologic Lyme, but that's about it. You can put it all in one slide, the recommendations that stand out from the IDSA guidelines. And the IDSA happened to have a table at the end where they didn't dwell on it. They just threw in a bunch of things they said absolutely shouldn't be done, shouldn't be prescribed. And this is a subset of that list. You shouldn't treat chronic Lyme disease, no antibiotics more than 10 to 21 days. You shouldn't have multiple repeated courses of antibiotics for the same episode of Lyme. You shouldn't combine antibiotics. No benzathine penicillin, no fluoroquinolones, metronidazole, tinidazole, or Bactrim. You shouldn't be treating for babesia unless you have active babesia, and that's usually only by a thick smear looking at parasites in the red cells under the microscope, and you shouldn't be treating Bartonella. So none of that was based on much research. It's just based on that society getting together and making a list for a table of what shouldn't be done. Usually if you're going to say absolutely nothing should be done, that's usually based on some research. So what ILADS did was publish the guidelines 2004, and then this is the latest one, where a lot of work was done with 2 of my colleagues, Lorraine Johnson, who is from LymeDisease.org in California, and Betty Maloney, who's very active with us in ILADS and with LDA, with Pat Smith's group, as well as the full board. So we did is we used GRADE, which is a special way of looking at evidence. Instead of just glancing at it, you actually have to measure it and assess it and look at how valid the data is. So, for example, when we look at prophylactic treatment for a rash, when we look at prophylactic treatment for a tick bite, they were not basing it on as big a study as you might think. If they gave 2 doxycycline pills to one group, they had a rash. Those they give the placebo to, they had 8 rashes. So, if you were the ones over there with the placebo, you got more rashes, 8 more rashes, and if you were in the 2 doxycycline on that side of the room, you get 1 rash. So they said, yep, you could prevent rashes, therefore you could prevent Lyme. But knowing Lyme, as we know in ILADS, is Lyme is more complicated than a rash. They didn't follow anybody more than 5 weeks. They didn't look for symptoms. They didn't trust symptoms. So all I can say with 2 doxycycline pill is that you can prevent a rash. not the kind of Lyme that I'm interested in. The second thing we did is we took every last EM trial, erythema migrans trial that we could find, and there were over 10 that reported long-term follow-up. There was always some studies that just said, is the rash gone? We only picked the ones that where there was a continued rash, or continued symptoms or continued problems a year later, and we found that the failure rate at a year was 33 to 36% for doxycycline, 16 to 48% for the amoxicillin, 22% was Zithromax, and 21 to 48% was Ceftin. So there was a much higher failure rate. Now these included people who were ill with symptoms, included people who were retreated, people with neurologic issues, but it also included people who were lost to follow-up. And in the way intent to treatment is done, loss to follow-up is extremely important, because if they're out of sight, out of mind, they're counted as a failure. We also looked, in a very analytical fashion at what's wrong with the retreatment trials. And the 4 retreatment trials that the NIH sponsored were all small. The biggest study was 70 patients from the Klempner seropositive group. The smallest was 37 from the Fallon's-Columbia group. So we're making a lot of big conclusions with very little data. Remember I told you about poor generalizability? Is that the Klempner subjects were sick 4.7 years before they entered the study. Now they didn't have to be sick that long. They asked for volunteers. It just so happened that's the kind of people that were showing up for enrollment in the meeting. The Klempner patients had been sick for three previous times with 3 previous treatments. The Fallon were sick for 9 years. In fact, the Fallon's paper says that only 1% were actually eligible for the study. They had to exclude 99% of the patients that came in for an evaluation. Treatment delayed was not addressed as a confounder. That is, before you even got your first treatment, was there a serious treatment delay? And Fallon reported 1.8-year treatment delay. Then the Klempner paper didn't even mention how long there was a treatment delay. We already know that if you treat it right at the time of the rash, you're more likely to have a good outcome. And also that when they say the NIH trials were a complete waste, there were actually gains that they had overlooked. Like the Krupp paper had a significant gain. 64% of those who were treated with 4 weeks of IV did great, whereas only 18% of placebo did great. In the Fallon paper, 66.7% improved on fatigue versus 25% in the placebo. And there was a strong trend in the Fallon paper for pain and cognitive improvements, but because it was only a few patients, they couldn't reach statistical significance. So we felt that, that it was important to get that data out, make it clear that that data supports a second look. And we came to this recommendation, that in the grade system, recommendations take into account not only the quality of the evidence, but you also have to balance the evidence, the benefits and harms, and values and preferences. This is the state of the art. If you're really, really sick, you should take that into account. If you're barely sick, you might decide that the side effects are greater than just letting it go. Also, the grade promoted patient-centered care. Patient-centered care focuses on achieving treatment outcomes. Remember, the IDSA was 21 days and that's it. No further treatment, no extended treatment. Doesn't depend on how long they've been sick, doesn't depend on how sick they are. But an ILADS guideline, patient-centered care, focuses on achieving treatment outcomes that restore the patient's value, including the restoration of health, prevention of health deterioration, and the provision of treatments that have the potential to improve quality of life. And shared decision-making was in the guidelines. That shared decision-making takes into account the best scientific evidence available, clinical expertise, and the role of patients' values and preferences. That is, you should talk to the patient, include them in the discussion of the risks and benefits. So, you might say, well, we have ILADS guidelines, IDSA guidelines. How do you get one doctor to pick a guideline or stick with a guideline? So in my work, I ran across this one image which says not all doctors are alike. There's, in a bell-shaped curve, there's some innovators on the left of your screen, early adopters, and on the far right are late majority and laggards. And so the sociologists say that doctors who look at Lyme might be innovators, early adopters. So what happened is that in the 20th century, it seemed like the IDSA took over as innovators. That is 21 days of treatment, 2 doxycycline pills for a tick bite, and no retreatment was the innovation. And that ILADS was portrayed, there was a narrative that ILADS was the laggards. Get over it, just deal with it, go away, don't be bothered. So the question is in the next century is that, you know, how can we get ILADS to be the innovators, early adopters, and how can we put IDSA more in the laggard? Like, can they get with the point? Can they get on with patient-centered care? Can they have shared decision-making? And can they have more outcome-driven treatment that really we do and we expect for every other illness? So I wanted to spend some time on how do we get to this point? How can we affect change? How can we get somewhere? This is from that same sociologic curve, is that same bell-shaped curve. But if you look at that bell-shaped curve, you see the yellow line is that you don't have to get the laggards to change. You only have to get the innovators, early adopters, and early majority to start approving. In fact, you only need 10% of doctors to take on change in order to have everybody else flip. So that's why over here, that thing, you just need to get the innovators, early adopters get going, and you forget about the laggards. So if you portray the IDSA as laggards and just let them go and not force them to change, they may have to go with the program. So I wanted to spend the next few slides on, are we getting anywhere? So the ILADS guidelines, there's a typo there, but the ILADS guidelines, we got notice that they were downloaded 107,000 times. Not just viewed, not just shared, but there was 107,000 downloads, which Altmetric, which is, you know, keeps track of 180 open access journals, said that puts it in the top 5% of all research articles as scored by Altmetric, which means is that we're having a big presence. People are actually downloading, and hopefully it'll affect change. The second thing that I noticed in this one paper, they had looked at how many people are being treated with extended therapy or prolonged therapy in the Northeast United States with an insurance database. And they found that there were 684 cases that were treated longer than 5 weeks. And it was actually not just 20 doctors. There were 20 doctors who did a lot of the work with chronic Lyme, complicated Lyme, but it was really 488 total doctors that did treat longer. And the 16 or so who were treating a lot of patients, and they compared them to those who only treated a few. Their overall prescribing is measured by average number of antibiotic exposure days, number of refills, and multiple antibiotics prescribed did not differ with their peers. So it seems as if there's some innovators and early adopters out there in the Northeast. I mean, and you hear it through ILADS that there's a lot of other people out there that are gradually doing it for individual patients. So the question is, how do I encourage them? So I wanted to spend a little time on, instead of putting a guideline out, disseminate a guideline, having people read the guideline. Often the guidelines tend to be kind of stale or kind of old, and there's so much new data pouring in. You're kind of curious when you're sick as to, is there something new? Is there something new that would help me in my practice, help me in my treatment? So I wanted to tell you that I've been spending more time not on writing guidelines right now, because they're done, they're in the literature, they're peer-reviewed, they were listed in the National Guideline Clearinghouse, they're all set But blogging is a chance to like make the guidelines more alive. So this is the Facebook. I have, as of today, I had 4,106 likes. But likes are interesting because whether you like it, put a like or not on a Facebook, is that people share these things anyway, whether they click the word like. And so it's there's an endless amount of things to repost. But most important is that I try to do a blog a week to take something fresh from the literature and dig into the literature. So that's why on my website, I do something called All Things Lyme blog to try to dig into these topics. A lot of these topics, it's coming from an article and you don't have much experience reading the article, or even worse, the article's not open access. You can't get to the article, you can't study the article if you can't even access it. So people click on the All Things Lyme blog, which is, where is it? Yeah, over on the, right there, and then click that. There's the archive one also. So I wanted to give you some examples. So this is one that says tick-borne co-infections are the norm. Because years ago, having early Lyme was the norm. That was the 70s. Having chronic neurologic Lyme was 1990, 26 years ago. It was in New England Journal of Medicine by the same doctor Dr. Steer, who wrote about Lyme and discovered Lyme. But now the literature is full of co-infections. So this blog is titled Tick-Borne Co-Infections are the Norm, Not the Exception. So if you click on the button, go inside the blog, it says, based on his Trends in Parasitology 2015, that researchers from 3 leading institutions, including Columbia University, Tufts Medical Center, and Yale School of Medicine, recently examined the extent of co-infections in patients diagnosed with Lyme disease, and they found 4 things. 40% of patients with Lyme disease experience concurrent babesia. So in my practice, even though I look for sweats, look for air hunger, look for something unique, if 40% of the time they have Lyme, that's quite important. So I often will end up doing something for babesia. Babesia treatment is different than Lyme. You often have to use something for a parasite, like Mepron is atrovaquone. Sometimes that's expensive, so I might have to use Flagyl. 13% of the patients with Lyme disease experience concurrent HGA, which is anaplasmosis. And Pat did a good job of laying out anaplasmosis earlier. 2/3 of patients with babesia experience concurrent Lyme, and 1/3 of anaplasmosis. So it goes both ways. So they've already shown a study that if you have Lyme and babesia at the same time, it's more serious. And 1/3 of patients with babesia have concurrent anaplasmosis. Another example of a blog that's in my website is how Lyme myocarditis might present in an adolescent patient. So it gets into the article itself, which is not open access. How did the patient present, and how did they get discovered, and what was the treatment for this adolescent patient with myocarditis? What you might look for, what did they look for? Travelers heading south cannot escape the threat of tick-borne diseases. So it goes into a strain of Lyme in the south from a tick. And this one is a really big door for persister cells survive attack by antibiotics and may contribute to chronic illness in Lyme disease patients. This is work that Pat Smith was talking about earlier that they're supporting as the LDA, is that this research is coming out of tuberculosis, that tuberculosis is tough to treat because there's some persister cells that are hard to get rid of in tuberculosis, but it seems like in a test tube at least, it's hard to treat Lyme disease, and because about 10% of them are hard to treat. So this goes right into the details of what that paper said, what the article means, and it gives a critical analysis. The nice thing about this series of blog papers is that it reinforces the guidelines to some degree. It gets a more readable reference base. You can actually see the references I'm referring to. and you can push click and it gives a printable copy. It's a 2-page printable copy, and it tries to make it more alive when you disseminate the guidelines. The next thing I wanted to do is that I wanted to try something new, which is a video blog. The VLOG is what they call it. So I did my first one 2 weeks ago, and I don't have it. I don't have it with me, but I have the slides that went into the video blog. What I wanted to do a video blog was to make it this epidemiologic-based analytic review more alive. So I wanted to show you what I did with this New England Journal of Medicine article that came out 2 weeks ago. This was a New England Journal of Medicine article by authors from Norway. And they had 281 patients in this treatment trial. The average age was 43 to 48, 53 to 56% were men, 27% had a rash, 29% had IgM, 64% had IgG. They were sick 2.7 years on average. So once again, you're dealing with the patients who've been sick for a while. They had 2 previous treatments, and if you added up all their prior treatment, it was between 30 and 40 days, which means they weren't treated more than the standard IDSA length of 10 to 20 days. They had typical symptoms in this Norwegian trial of arthralgias, musculoskeletal pain, sensory disturbance, neuralgias, neurocognitive symptoms, and fatigue. The quality of life of those in the Norwegian trial, I put a ruler on the left. The quality of life for the general population is 50. Diabetic and cancer patients is 42 to 41. The Fallon trial was 37, Klampner was 32, and the Norwegian trial subjects were 31 to 32, which means their quality of life was worse than cancer, diabetes, and anything the NIH has ever seen. And these are European patients, so it means that we don't have all the sick patients in the United States. The kind of studies using short form 36 are relying on these type of questions. Compared to 1 year ago, how would you rate your health in general now? Were you limited in the kind of work or other activities? How much physical pain have you had during the past 4 weeks? These are rather important questions that affect your life as a mother, if you're trying to go to school, trying to get to college, trying to work. In that Norwegian trial, they were all given 2 weeks of IV Rocephin. The first group, they added 12 weeks of oral doxycycline. Second group, they added oral Bioxin with Plaquenil. And the third group was 12 weeks of placebo. So you see on that graph is that way over on the left, can't see it, but over on the left, there was the, you see how poor the quality of life is for all 3 groups? Right here, 30 to 32, pretty poor. But over the course of the year, they still ended up about 35. So they were still pretty crappy. They were still worse than diabetic and heart attack patients. And whether they had any of the 3 treatments, and they're listed here, they all had about the same outcome. So they gained 3 points on a physical health scale. But the main problem that they had was that they're 15 points short of where you want to be as a normal human being. And so, in fact, they all failed. They didn't really get what they wanted. And what you really want in life is to get better. So when they published this paper, and they published an editorial in the New England Journal of Medicine, is that everybody picked up on it in the media saying, long-term antibiotics fail again in Lyme disease. Prolonged therapy shows no benefits for persistent Lyme disease symptoms. And some other ones said 2 weeks was no, or 2 weeks and 14 weeks didn't make any difference. And so the main concern is that misinterpretation of that study. So if you're looking at it the way this is laid out, is that if all you get is 3 points, is that we just didn't have a protocol that's really effective for these kind of patients they were seeing in Norway. So some of the problems with the Norwegian study were the poor quality of life on enrollment. There were retreatment delays of 2.7 years. They didn't evaluate for co-infections like Babesia, which would require different treatment. and no individualized therapy, we already know that 4 weeks of intravenous is better than 2 weeks based on some papers by Legigian, and all they offer was 2 weeks. Maybe 4 weeks for everybody would have done much better. Or basing your protocol on outcome. If they didn't get better with one treatment, why not try the other one? So the editorial should have addressed the need for better outcomes for patients with symptoms attributed to Lyme disease. They could have called for more effective initial treatment. It's a shame they have to wait 2.7 years. We already know from strokes that you should get treated within the hour. If you get a heart disease, you should get treated within 6 hours. If you have diabetes, you should treat earlier, not 20 years after the fact. Earlier retreatment, you shouldn't wait 2.7 years. You should treat for co-infections and individualized treatment. So what happens is that there was a different paper that I want to write another video blog that came out in JAMA last week. I haven't written it yet, but I'm just starting to frame how to look at that article. This was an article by a group that looked at all the literature. They said they looked at every article on Lyme, and they decided that all you need is 10 days of antibiotics for Lyme, that's it, nothing more, and 2 weeks of treatment for Babesia and nothing more. You might go longer on Babesia if they have severely immunocompromised type illness, but if you look at it, they didn't give any of the data. Remember all the data I gave you on grade analysis and ILADS guidelines, is that they didn't give any of the detail how they came up with 10 days. They didn't mention chronic Lyme, chronic manifestation Lyme, neurologic Lyme, any of those things. But just to give you an example of one paper they did cite was they cited this 2008 Norwegian trial where they compared 14 days of doxycycline with 14 days of IV Rocephin. And all they said was there was no treatment failures, which is really true. There were no treatment failures in that study. But what they didn't include when you go look at the original paper is that 59% of those patients were sick after 14 days, including 11 facial palsies or cranial neuropathies, 10 had radiculopathy, 2 paresis, 1 possible encephalopathy, and 1 unsteadiness. And so by not looking methodically and not having a transparent paper, you run into these kind of JAMA statements, and you can see these kind of things are going to get quoted by doctors. So the reason for blogs and video blogs, and I'm encouraging others of those who speak at meetings, is to get to know a few of these facts so you can kind of counterbalance these kind of papers. So what I wanted to do was, in my remaining time, was to get a little more practical. Because it's when you talk about guidelines, whether it's writing research papers, doing guidelines, or blogging, it seems like it's a great read and a great to get to know things, but ultimately you have to practice. So at the main meeting, I presented this case that when you're ready to jump out of an airplane, this British Medical Journal said that they haven't really had a trial to prove that you should use a parachute. And so it's one of those things that for those who insist on treating Lyme, but only if they have a double-blind and randomized placebo-controlled study, that's perfect. If they won't treat for more than 2 doxycycline pills if they have the right trial, is that ultimately the solution by this author was that if you really feel that strongly that everything you do in life has to be part of a formal trial, you should do these things. First, as with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subjected to rigorous evaluation by using randomized controlled study. We think that everyone might benefit if the most radical protagonists of evidence-based medicine organized and participated in a double-blind randomized placebo-controlled crossover which crossover is a funny thing, is that if you sign your name saying, I believe in evidence-based medicine, you agree to be in the study. So one group jumps without the parachute, and the group that does have the parachute, they're guaranteeing that they're going to jump the second time without the parachute. That's what a crossover is. So everybody gets to jump without the parachute to truly prove that evidence-based medicine works. So in actual practice is that besides trials, the father of evidence-based medicine, Dr. Sackett, said yes, you should have research evidence, but you should also integrate clinical expertise and patient values with it. So that's why I want to spend a little bit of time on not double-blind trials, but what's the best evidence we have for me to practice in medicine. So we do know that ticks have been around a while. So this study found 4 ticks in amber, that thick, gooey stuff that came off fossilized trees 15 million years ago, and they found 4 ticks. And the same type of ticks we have now, and a very similar infection with Borrelia that we have now. We have these ticks that evolve for many years, and so you see the nymph and the adult female are different size, but they both carry a lot of different organisms. We're only beginning to understand what's in those ticks. This was a frozen guy in the Alps. They found he had been frozen for 5,300 years in the Austria-Italian area, and when they took him down, they found out with a deep biopsy that the only disease that he had was Lyme disease. And he had an arrow in his shoulder, but he had some reindeer in his stomach. So he was healthy enough to catch a reindeer and eat a reindeer, even with his Lyme disease. So it shows that Lyme disease didn't kill him, but the arrow probably did. But it shows you Lyme been around a while. This is one that Pat Smith went through. So the reason I included this was not to talk about the fact that half the counties in America have it, is that the authors say that they just don't have information in the other half of the states. There's no money, nobody out there, nobody looking, and so that doesn't mean they're there. They just don't have the resources to commit to all the white areas to find out where the ticks are. And Pat Smith did a good job of laying out all these overlapping distribution of ticks. The other thing is that just what you think is related to moose, related to deer, is that birds are moving ticks all over. So in Minnesota, Wisconsin, they found as early as 1989, 250 larvae, nymphs, birds, all kinds of birds having ticks. And when they did a tick study, they looked at birds crossing from the United States to Canada. They looked at how many ticks were on the birds and how many birds, there were quite a few birds. So they found that up to 175 million deer ticks were making it to Canada every spring to Canada. Because what they do is they feed for 3 or 4 days and fall off, but a bird moves pretty quick, so they can carry a lot of ticks to Canada. And it just shows you that birds go both ways, and not all birds go north. Some of them go east and west. There's a guy, specialist in Georgia, who says that a wren doesn't go north and south, it goes east and west, from Georgia to Mississippi. So whatever was happening is there's an endless amount of birds moving ticks into new locations. And so when Pat Smith laid out that there's the Lone Star ticks moving fast and being found in new locations all over the place, some of it's probably from birds and moving these things around. Just to give you a little idea more of Lyme itself, what we actually see in our office is that before politics came along, this was the very, very first paper in 1977 where only Polly Murray, a housewife from Lyme, Connecticut, working with Steer and a couple of his colleagues, described Lyme disease. They said there's a Somehow there's a group of kids, 39 kids, 12 adults, who have swelling that's asymmetric in the large joints. There's attacks that last 1 week to 2.5 months, 3 recurrences, 25% rash, head rashes. And so already, if you look at the first paper, a lot of the things we talk about in ILADS that we talk about with chronic manifestations of Lyme were already described in 1977 before the paper even got published, before anybody could react, before the insurance companies could get involved, before disability companies could intervene. So it just shows you how this chronic Lyme issue that some people say doesn't exist, the narrative was already there in 1977. And the people having no rash, that narrative was there already. So what they did was they found in 1990, 13 years later, Dr. Steer, who had discovered Lyme with Polly Murray, wrote this paper up that for some reason these people were sick for up to 14 years with this unexplained illness, with a wide range of symptoms. The way I like to refer to it is that the immune system is busy trying to fight Lyme, and it's overactive, and that's why you get tired and drained. You can't sleep very well. You wake up tired. You can't focus, can't process information as fast. Every neurotransmitter that affects mood, including irritability, is off. The adrenaline is too high, therefore people are lightheaded. They can't stand up as quickly or bend over as quickly. They get palpitations when they move, and they get some tingling in their extremities because the immune system is so busy attacking Lyme, it happens to attack the coating of the nerves. And that package of symptoms was described in 1990. I'd been in practice for 3 years, and I thought, this should validate what I've been seeing for the last 3 years. That should be all it should take, and there should be able to be a lot more comfort in taking care of Lyme. They also found that 2 weeks of IV worked, but the improvement was seldom complete. And so the seldom complete has become a subject of great controversy, because if you're being told by a doctor you're better, seldom complete can be kind of messy. And you find that that quality of life going up by 3 points doesn't do you much good if you really want to go up to a normal, healthy, active kid, adult, a worker. And also some of them were relapsing. This was only 2 weeks. 4 weeks was better than 2 weeks on a subsequent study. So by now, there's all kinds of complications of Lyme disease. I'm referring to it as complications here instead of chronic Lyme disease because there's a lot of diversity. Chronic Lyme disease was described by Legigian as Lyme encephalopathy. Bloom described neurocognitive changes in kids. There's post-Lyme disease syndrome is a favorite term for a lot of people now. I don't like it because it implies that Lyme is gone, but it was used by the Krupp trial. Neuropsychiatric Lyme was talked about by Fallon, where they presented with all kinds of psych issues. Post-Lyme disease syndrome was by Alcott. He's this gentleman at Hopkins who gives you 3 weeks of treatment. If you're not better, he puts you in a study and follows you over time to see what happens to you. About 40% are still sick. Sensory neuropathy, remember I said there's tingling in the hands and feet? Well, that turns out for quite a few people, they can actually prove neuropathy with EMG, where they stick needles in your muscles, and they can prove it in the legs. And POTS is this adrenaline, this autonomic nervous system that's too active, and it gives you tachycardia. And then some carditis cases. These POTS, which is when you're positional, you change position. This author was able to measure the POTS. They put them on a tilt table, tilted that table quick to see if their heart rate would go up. And they also had fatigue, cognitive impairment, and orthostatic intolerance. This was published in a 2011 journal. This is the Bloom paper where 14% of kids had behavioral changes, forgetfulness, declining school performance, headaches, fatigue. I like the partial complex seizure disorder, which is really hard to measure. And a lot of psychiatrists in our area are liking to call that psychiatric or call it conversion disorder rather than part of a medical illness. We also, in practice, have to address what Pat was referring to, which is as early as 1998, it was pretty clear that Lyme is not always Lyme. There's Lyme with Babesia, Lyme with Ehrlichia, and Lyme with anaplasmosis, or all of the above. And then you throw in that the whole Northeast, there's a lot of Borrelia miyamotoi in the same ticks. Fluosin is really hard to address because it's hard to measure. So I don't really measure that on a regular basis. The other thing that makes it complicated, besides all the diversity of bacteria in a tick, is that if you look at that curve over here, this bell-shaped curve, that's the ELISA for the people who don't have Lyme. The people with Lyme have a bell-shaped curve also, but look at that big overlap. All these people that are in this group would be seronegative. The positives are only Lyme patients that are 3 standard deviations above the mean. That means you have to have a pretty strong reading. The other thing that happens on a Western blot is that you have to indirectly measure Lyme through antibodies. You're not directly measuring the infection. So they decided by committee years ago in 1994 that you should get 2 of these bands or 5 of these. That means they're trying to look at these smudges, but they don't have these markers on when you do a Western blot. You just see these smudges. So I should have a slide where you don't see all these things and try to see if you can match which protein is with which smudge. The other thing is that you also have to have both this and this, so that makes the sensitivity poor. The other thing that happened is that these 2 bands, 31, 34, are not on the CDC list of bands to look for. These over here, these are common proteins, and so it's kind of a mess. The Western blot is not as sensitive as you might like. When it comes to Lyme, is that it also looks like a lot of other things. So what a lot of other doctors do is that they'll jump on the first diagnosis that they see, like fibromyalgia, chronic fatigue, or ALS, or polymyalgia rheumatica. We're going to hear a little bit of discussion this afternoon of how easy it is to jump on one diagnosis. That's called an anchor bias. An anchor bias is you throw out the anchor and hold on to it, and everything has to go around with whatever diagnosis you pick in the first place, no matter what you do. And nobody pulls up anchor and says, well, could it be Lyme after all? Whenever you work with Lyme, you have to do a bunch of other blood tests. There's usually, over time, there's a lot of other specialists to see, because one thing about Lyme is one visit usually is never enough. You got to follow that person. If they haven't seen a neurologist and they're still sick, I'll often add a neurologist to their workup. Now, the last 2 slides are busy slides, but I wanted to at least point them out anyway, is that I have patients who come in knowing that they have a biofilm and they need something for biofilm based on everything they've read, or they need something for cyst buster. And it just seems logical to, and a number of my colleagues write about how the illness is from these types of filming materials where you can't get the antibiotic into the material. But what I tell them is that just because there's a lot of good research coming in on biofilms and cystic issues, there's a lot of research that it could be that the Lyme is hitting the myelin coating of the nerve. It's in the brain. There's different antibiotic susceptibility. We don't even begin to know which antibiotic is the right one for you. There's different clones with different proteins that each spirochete's different. Each spirochete produces different genes. It goes from an outer surface protein A to outer surface protein C just by getting into your warm body. Each person's immune system is different. There's immune activation. There's intracellular locations. It just shows that there's many more organisms. It could be a co-infection that's giving the problem. So I don't like to jump to just one mechanism when I treat somebody. So therefore, when I treat somebody, I don't like to just pick the biofilm or the cyst as the only way to go. In fact, if anything, there's so many other mechanisms that are available that explain Lyme, is that There's oral antibiotics. Not everybody should just be treated with doxycycline. Most of you know in the room that there's the amoxicillin family, the Zithromax family. There's drugs that come up if you're worried about Bartonella. The intravenous is an option, but lots of times, over 90% of the time, if you get somebody in a timely manner, you can eventually get them better with just oral rather than intravenous. Intramuscular, I like to do that only if I've done these other two things first. And I usually use penicillin VK instead of bicillin, but many of my colleagues use bicillin. Sometimes there's more than one condition. They might have Lyme and diabetes, or Lyme and a concussion. A lot of people they blame everything on concussion now, and they might have concussion and Lyme. I have the option of going longer on an antibiotic. Sometimes with amoxicillin, I do 2 pills 3 times a day instead of 1 pill 3 times a day. Sometimes it looks like I have to do IV, but I do well with oral. IV only works for Lyme. It doesn't work for Bartonella, Babesia, Ehrlichia, anaplasmosis. Sometimes I use 2 antibiotics at once, like Zithromax with Ceftin. Or sometimes I can't get an antibiotic to work until I treat for Babesia. So I might eventually have to do something for that. I might have to retreat. I might have to fight a co-infection and then get back to Lyme. So when I first see somebody, you know, if I take just these examples of what's typically in here, and Pat laid that out already, is that it's hard to have one antibiotic like doxycycline work for this, but it doesn't work for Babesia. Minocycline's the same thing. So lots of times I might pick doxycycline first if they can handle the sun, handle everything, because it fights most of the infections, but I move to something for Babesia quicker than you might think. And I use this because it's cheaper for those who don't have good coverage with their prescription plan. This can cost like $1,000 for a bottle for a month. So there's a lot of options for treatment of Lyme besides the antibiotics. For everybody, I try to avoid processed sugars and alcohol. I try to get them moving somehow, and if they have a job, try to hold on to it. You know, you can't give up being a mother, but it's still tough. As a kid, it's really tough to stay with school, but I try to do that. I do a lot of work with counseling because emotionally they're in trouble. I do behavior modifications. I do a lot of things to work on trying to get them moving, handle all of the despair that they get. I have to treat their pain, their sleep, their fatigue as best I can. Those medicines don't work that well. I'm always looking for side effects. I don't like to hear a Herxheimer reaction because they might be allergic, they might be sensitive to a drug, there might be something else going on, so I want to hear the details. I tell them about the flare-up that they get when they start with an antibiotic. I try to be careful with the sun. If they're with doxycycline, try to be careful to start out slower for a lot of people who have upset stomach. A lot of people have kind of an irritable bowel type feeling where they can't take antibiotics very much, so I have to start out slow. I don't really do anything in the alternative complementary field. I leave that up to the people that do that kind of work. So most of my work is all up here, but that's still enough to fill up an office visit. And IVIG I don't do that one, but some of the neurologists do that for some of the neurologic complications. So the last 2 slides I have is that now that you've been through that sequence, you find these things in the literature. Like this one was in 2015 where somebody had a new onset panic, depression, suicidal thoughts, somatic symptoms in a patient with a history of Lyme. But when we read the paper, he had Babesia. And they talked about Babesia, but they didn't treat for Babesia. All they did was give cognitive behavioral therapy, psychiatric therapy, but they might have done better if they had retreated more than the standard therapy or treated for Babesia. And this was that 17-year-old with the fatal cardiac Lyme carditis. Somebody had gone to camp in our area, came back from camp quite sick, and they spent 3 or 4 weeks trying to find an answer. They did the Lyme test didn't show it, and then he was found dead, and his Lyme was full, his heart was full of Lyme in the heart tissue. And so if they had not worried so much about the test and just said if it looked like Lyme, sounded like Lyme, you got out of camp, and that instead of going back to that parachute where should you wait and put that parachute on or not, is that he might have done better if he had just got out with an antibiotic at that point, since he just came back from camp. So I think when you look at evidence, you get evidence research. I've been working for 29 years, working and obsessing on evidence, but ultimately is in practice, I don't have all of the evidence I need to do what I need to do, and none of us who work with Lyme have all the evidence we need to do. I always want to encourage anybody to get to know literature as best as possible so that they can understand it better. It also, this thing I'm on now, which is blogging and video blogging and things like that, and the Facebook, is to try to bring people up to date with timely information of things that you can't really get all the time, waiting for a guideline to come out. So thank you very much for this heavy session. Thank you very much. Okay.